It's been said that you should not let any tragedy go to waste. Well, coronavirus and COVID-19 is gearing up to be such an incident. And instead of talking about the scary aspects of COVID-19 and cause potential hysteria, Dr. Casperson and I are going to talk about the benefits of COVID-19. We're talking about taking care of patients remotely or telemedicine. We have been thinking about doing this for a long time, and this COVID-19 crisis kind of pushed us and moved us by leaps and bounds. We are now doing telemedicine in our urology practices. We have just implemented it, and we figured that based on what we went through, we would share our experiences to help everyone I know a lot of you are thinking about doing this because we both moderate the Thriving Urology Practice Facebook group, and the number of questions that are coming through is just crazy. So my DM is going off the charts, my text messaging, and Kelly has been also answering a lot of questions. She is a urologist from Washington, Bellingham, Washington. And thank you so much, Kelly, for being on the program and helping out everybody during this crazy time.
Happy to see you again, John.
Yeah, we've been talking about telemedicine for a while, and we've streamed quite a few seminars and discussions and interviews on the Thriving Urology Practice Facebook group, some of which you can find on YouTube. But what made you decide, okay, this is it, we got to do it, and how did you go about doing that?
Yeah, well, like you said, nothing like necessity. Something's the necessity of invention, father of invention. I think telemedicine's been clunky for a long time. It's been expensive for a long time. Getting insurance to pay for it has not always been a known entity. So there was a lot of reasons that I think a lot of people didn't adopt it. But now with patients they don't want to come to clinic, or maybe they're high risk for COVID, or for whatever reason, and for Medicare to say, hey, this is now going to be paid at inpatient clinic visits, it's making it completely reasonable. And the platforms to use it now are very straightforward. So the time is now.
Yeah, I agree. And I'm going to quickly let the audience know that we are streaming this live on Facebook. If you have any questions, please leave them in the comments, and I will read them and ask Kelly, and we'll try to answer them the best we can. We're going to talk about three general topics. One is the legal aspects of telemedicine, and number two, logistics. How do you actually implement it? I think this is the meat of our discussion. And lastly, we'll briefly talk about the billing, the coding aspect. I mean, each topic by itself it's a long, huge topic discussion. So we're going to quickly go over that, and more importantly, we'll try to answer people's questions, because I think that's what's going to bring everyone the most value. From a legal aspect, what things have you done, Kelly, on your end before you implemented telemedicine?
Yeah, so the first thing we did is we checked with our med-mal practice insurer and said, this is what we're going to do. What's our coverage? We already have coverage for follow-up visits. So they said, go ahead. So that's what we made sure was in place first. So we just started with follow-up visits, and then we do a verbal consent with patients when it's being scheduled and saying, hey, do you consent to this? It will be run through your insurance. So med-mal says it's okay, and then a verbal consent from patients as they're being scheduled. Got
it. That's exactly what we did. Medical malpractice insurance, talked to them first, and they gave us, interesting, the underwriter asked some interesting questions. One, where will you be doing telemedicine? Where will I be providing telemedicine services? And number two, where are the patients going to be located? So the important thing for everyone to understand is that wherever you are providing the service, like for instance, I'm here in Arizona, I need to be licensed to practice in Arizona. And wherever the patient is located, I need to be licensed to practice wherever the patient's located. So that's important to know. There is very minimal reciprocity among the states. So there may be some exceptions if you are in Arizona and then say in California, there are not urologists nearby, maybe a 50-mile radius. You have an Arizona physician may have the ability to maybe just see follow-ups, but those instances are very rare. So it's important for you individual physicians and providers, nurse practitioners, and PAs to make sure that you have med-mal coverage. What is that coverage? And also your limitations as to where you can and cannot practice.
Yeah, and to add two things to that, John. Number one, we have a established patient here who's in Hawaii, doesn't want to fly back right now and said, can I do a televisit? And we just chose to say no, because their location is currently in Hawaii. And we were just like, no, we got to keep it to doctors and patients being in Washington State. And then number two, I just saw something today on a federal level looking at getting rid of necessity to be in states because of the COVID and saying, hey, we need doctors now in Oregon. Let's let other doctors come practice in Oregon. So I don't know where that's going to go. But again, the necessity of COVID might really open up borders for doctors.
Yeah, nothing like a big crisis to force things to happen quickly. Mm-hmm. The other thing is, I cannot be in Hawaii and doing telemedicine visits of patients in Arizona. So that's something to keep in mind. You also said something about verbal consents. I know Medicare has relaxed the consent ability by using telemedicine. So that is something that you all should keep in mind. And also you should all at least obtain a verbal consent and document that in the EHR whenever you see telemedicine patients. And actually, I'm going to show a screenshot of a consent that I personally use for telemedicine. And I obtained this consent from my medical malpractice insurer, and we simply modified it to fit our needs. So legal issue number one, patient needs to be in the state in which you are licensed to practice, and you need to be in the state in which you're licensed to practice. Medicine is such a regulated industry. It is insane, the hoops that we have to jump through. And this is part of the reason why we have to keep talking about this telemedicine issue, because it is not just actually providing service. Providing care is the easy part. It's all the logistics, the legal aspects, the financial, the billing, coding aspects, the federal mandates that we have to adhere to. And more importantly, for everyone, you have to, even though the government says you can do this, you can do that, from the federal level, you need to consult your state rules and make sure you are compliant with your state rules.
Right. Yeah, and I think, the other thing that I hope people understand is we are not the end all be all on this. We're learning. We want to share our information with people, but trust but verify.
100%. We definitely are not lawyers, and we are not giving you legal advice. So always verify and trust. Okay, so legally, so John, go ahead.
How are you having your patients sign a consent form for telemedicine?
So we are emailing them, and then they can. My staff is having them take a screenshot of their signed consent and then sending it back to us.
Okay, cool.
And I do the verbal consent, and I have a phrase actually set up in my EHR. And actually, you know what? I can hop into my EHR right now and read everyone what I have written down. So I use a short, whatchamacallit, an auto replace text or a dot phrase for those of you using different EHR platforms. And this is the phrase that I have set up. Telemed visit, : I obtain verbal informed consent from patient to proceed with virtual visit, patient voice understanding regarding benefits, risks, alternatives, and option to not participate. Patient desires to proceed with telemedicine visit, period. So that is the consent that I write in my EHR after I told the patient, hey, we don't have to do this. This is kind of limited. I can't examine you. I can't do a lot of things. Are you okay with us doing this? And they said, yeah. So, and I document that.
We have a dot phrase that we're putting in all of our clinic notes. So we're opening for, again, we'll get into this as far as like workflow goes, but we're opening a chart note just like it'd be a clinic visit note to have all your key pieces that are needed. And then we just have a dot phrase in the plan that says this is a telemedicine visit, patient consents, they understand there is will be a bill charge. Same thing. Just a dot phrase we're putting in there.
Jackie says that looks like a very long disclaimer as far as the consent that I showed on the screen. Many of our patients would have a problem understanding it. Well, I guess you're not going to operate on them at all, because if they have a trouble understanding language that is written in 6th grade, you probably are not going to be able to get a consent. Okay, let's go into logistics, which I think is the most important part of getting telemedicine set up in the practice to run successfully and smoothly. How did you guys start?
So how we did it is you learn by doing, right? So we're day 4 on this now. We have the receptionist. So we have scheduled patients, and the doctors are reviewing their days and saying, hey, I think these are the patients that would qualify for a online telemedicine. And so our receptionist calls them, says, hey, this is available. Would you be interested in doing that? They say yes. And then they confirm a smartphone number or an email address and make sure that that's in the chart. So step 1 is the receptionist reaching out and saying, hey, can we convert our pre-existing, and then making sure that they have an availability to do telemed, which for us with Doxy.me, you can invite them either via email link or smartphone.
Okay, so you're going into patient selection on who and how you actually get that link to the patient. For us, we started with a couple of staff meetings and just everyone sitting down, powwowing. My office manager wrote down a list of things that she's thinking about. Okay, this is how we think it's going to go. And we talked about the type of patients that we are thinking about seeing. And like you, I went through the patient schedule to see which ones would be a good candidate for a telemedicine visit. And we are doing just established patients only, meaning a patient that has already been seen in our practice. And then we pick, okay, which ones would be good for telemedicine, virtual visits, and then they would contact the patient. We capture their email address and their cell phone numbers as part of the routine intake, so we have that already. And we then send that link to Doxy.me, which is a particular virtual visit telemedicine platform that Kelly and I both happen to use, and we'll talk a little bit about that later. And then what happens is my medical assistants will reach out on like today before the telemedicine visit, and they actually start the encounter like you in the electronic health records, start the documentation, pull down the primary, write down the reason for visit, pull down the primary history of present illness documentation template, review the medications, review past medical surgical history, and update the review of systems. Obviously, my vital signs are not captured. And then my medical assistant will send that chart to me in a telemedicine inbox, if you will, meaning sending the chart to me with the title, this is a telemedicine visit. The chart has been updated and ready for me to see the patient. So she would do that on the day of the procedure. So it's as if the patient is here and they are doing everything that they would normally do if the patient's actually here. So they prep the chart, if you will, to make sure that the patient's visit virtually is as smooth as possible. I have all the information and everything's documented.
We're pretty similar. So say it's a 3 p.m. visit, my MA will actually call the patient at that time, enter everything, update the meds, all that stuff, and we'll confirm, do you want Dr. Casperson to be texting you or via your email? And they'll put that in the HPI too, like this is the cell phone or this is the email address. And then they can actually troubleshoot it. So with Doxy.me, you can actually invite any cell phone. So I did that with my nurses. So they see how it pops up. They see the buttons that they click. And so they have practiced coming into the Doxy.me. So they understand how to talk patients through it, which is very, very useful so that I don't have to do that. And they've been wonderful with the patients. I'm like, okay, you need to allow the camera. You need to allow the microphone. Especially I think in the older population, they have smartphones set up where they have that all blocked.
Yeah, my 62-year-old did not have any problems using Doxy.me virtual visit telemedicine.
Yep.
What is the?
And I had an 88-year-old today. He chose to do it through email.
There you go.
So we emailed him, and he can pull it up, and we're chatting on the couch. So yeah, I'm convinced if an 88-year-old can do it, we can do it.
So just to be clear, you emailed the link for that patient to click on to start a Doxy.me session. You're not.
Yeah, but you email through Doxy. So you're not using your personal email or anything like that. Doxy will just ask you, how do you want to invite somebody, cell phone or email, and you just put the email address in there.
Sure.
They get an email from Doxy.
Sure. I'm gonna go back a little bit. When it comes to workflow, my staff will actually look at the encounter or the appointment type and contact the patient ahead of time and collect any copay and things like that beforehand, a couple of days before. And like I said, the MA will update the chart the day of the procedure, and then when the time comes, the patient checks into the virtual waiting room, and then I start the encounter with the patient and go from there. When it comes to scheduling the patient, for us, we built in on our practice management software the template, a particular telemedicine visit type. So when it comes across to our electronic health records, it'll show up as telemedicine. So it'll show up on the schedule, the type of visit, and then the name of the patient, et cetera. Just like a real patient visit.
Same with us.
Okay, so make sure if you guys are thinking about implementing this, you're going to have to touch your practice management or scheduling software. You're going to have to touch your electronic health records. In the electronic health records, I set up a new virtual room, if you will, so the staff can send the chart to that virtual room, indicating that it's a telemedicine visit instead of a physical room. That's how we see patients here. So that's important. And
the other thing for us is I have dual screens, which I think dual screens are very useful for this. So I have my EMRs open on my desk screen, but then on my laptop where I have the camera, I'm using Doxy. So I can navigate both of the screens, which is a nice thing to do.
Absolutely. Dual screens, I've been advocating that for years. And at every workstation in our practice here, everybody's got dual screens.
And we've already figured out scribes too with this. So,
I was gonna ask you about scribes. I know you use a virtual. I can't live
without my scribe.
I know you use a virtual scribe in your practice. So how do you incorporate that?
So with Doxy.me, you can have multiple people in on the telehealth visit. So I get out of my scribe. I use Blue Jeans, which is kind of like Zoom for my scribe. We get out of that because you got to get out of your video and your audio, so it will work with Doxy. And then he has my email link just saved now. And so I will start the tele with the patient and then invite him in, and his video and audio are off.
Got it. So
that's how he can hear what's going on and document it.
Yeah. So we again, for those of you who are just joining, Kelly and I are both using Doxy.me, and Doxy.me is you can actually use it for free, and we are not being paid by Doxy.me. We just so happen to pick the same virtual visit telemedicine platform. It seems to work well for both of us, and that's why we keep talking about it. But Doxy.me allows you to have 5 people in the exam room at the same time. So you can actually have 5 people, yourself and then 4 other patients, if you will.
Mm-hmm. So John, are you using the professional one?
So Doxy has
paid versus free.
So Doxy has a free version and the paid version. I'm using the free version.
Cool. I'm using the professional version. My understanding is you can't have multiple people on the free.
Oh, okay. Well, very good.
But again, I don't know. I just started with the professional because it seemed like it made sense, and it's $35 a month.
Yeah, exactly. And
it's going to be okay.
So I'm going to give a plug to Doxy.me. The CEO, Brian Welch, is, I read in one of the interviews that he did, he sounds like someone who is very similar in mindset with Jeff Bezos. He is extremely customer centric. And that's why Doxy.me is free. It is super easy to use. Implementation in your practice and my practice, it's seamless and it's super easy. Just to give you some perspective, since CMS gave them a shout out on one of their forms, documents, they went from 2,500 sign-ons per month to 2,500 per hour. This was about 4 days ago. So,
unbelievable.
Yeah, so they had to really scale up their operations. But anyway, the reason I think he's going to have a wildly successful business is because he is extremely empathetic to the end consumer. making it super easy. I mean, gosh, the business associates agreement you can generate online, and it's just such a beautiful implementation. Now, there are some downsides to the standalone, non-integrated telemedicine platform. So you take the good with the bad. But for most of us who are thinking about just starting out, I think this is a very, very good way, an easy way to get started. And like Kelly said, it's only $30 some odd a month. Most of the other platforms are $200 to $300 a month.
Yeah.
And the onboarding is a lot more onerous.
Yeah, we got Doxy up. We got Doxy up and running in the morning, and I saw my first telehealth patient in the afternoon.
Yeah, and the other thing is, for those of you who are thinking about using Doxy, you can sign up, and you can actually have one of your employees act as a patient and sign in and hang in the waiting room, and then you can kind of practice on how to use Doxy.me. You're gonna be like, wow, that was it. It's super easy.
Super easy.
And for
if
me,
if an 88-year-old can do it, we can do it.
I know. And for me, it's super simple because I've had this studio set up already, and I've got 2 screens in front of me, and I've got this webcam that shoots in 4K. So it was like a natural progression for me to go into telemedicine, forced by COVID-19, actually really rapidly accelerated by COVID-19. Marina Cheng says, hi, John and Kelly. Providence is rolling this out next week. Your experience will be very helpful. So thank you so much for the comment. And Joe Hugh says something about appointment type tele. So it looks like they set up a new appointment type called tele. And Sam asked, did my first telemedicine visit today? Got to put the kids down. Hope I can see it later. Yes, you can watch. You'll be able to watch this on the replay. It'll take a few minutes for Facebook to render the HD version after we are done. And let's see. Joe says you can't text for the appointment on the free version either, only email. Okay, there you go.
Yep.
So that's Doxy. But we capture the patient's text message or the cell phone and email already, and we physically, my staff calls them to make sure that they're all set up. And Jackie asks, why can't you just document the conversation in the progress notes? And what do you mean by multiple people in the virtual visit?
Okay. So multiple people is multiple connections. So I can have a patient, and then her daughter is in Wisconsin and wants to listen, or my scribe listens. So that's multiple people. Is like, you don't all have to be in the same room. And if anybody's Zoomed before or done a Zoom meeting, it's very similar to that. Everybody pulls up, and you can just kind of see everybody that's in there.
Got it. And we are, as a matter of fact, Kelly and I are connected via Zoom right now, and this is being streamed from Zoom through a piece of software to Facebook Live. So this is, let's see.
And the other question was, why can't you just document? I missed the other part of her question.
Oh, why can't you just document the conversation in the progress notes? I don't quite understand that question. Why can't you document?
I'm not sure if that question is, why do you have to have video and not a telephone call, which we'll get to anyways.
Yeah.
Is that what that question is?
Yeah, maybe. But okay, logistics. Schedule, having a workflow, financial, and then the front desk contacted the patients. My medical assistant contacts the patient beforehand, sets everything up, and then the patient actually undergoes the virtual visit. We talked about the legal documentation, consent stuff, and then what happens after you see your virtual visit? What happens afterwards?
You finish your chart just like you normally would. You put in your orders just like you normally would. You renew the medications just like you normally would. And then you bill just as you normally would. You have to put in a code for telemedicine. But the follow-up patient visits are just as if you would see them in clinic.
Completely agree. When it comes to documentation, seems to be a lot of confusion for. Okay, so there's telemedicine, telehealth, and then e-visits. It is extremely confusing, but in our situation, what Kelly and I are talking about are, for instance, Medicare and private payers. You have new patients and established patients. We are seeing patients virtually as if we are seeing them in real life, and documenting the visit as if we're seeing them in real life, meaning we are billing by component when it comes to evaluation and management. I assume that's what you're doing, right, Kelly?
Yep.
Okay. So you can, when it comes to E&M visits, you can bill by component and you can bill by time. And it is just as easy, if not easier, to bill by component. And obviously, you have to have medical necessity, just like you would a real live visit. So we are billing by component using E&M follow-up visit CPTs, which are 9921, 212, 213, 214, and 215. So that's what we are doing. We are not doing remote care monitoring. We're not doing e-visit. We're not doing telehealth with the G2012 and then the 9942, 422, 423 codes. We are not doing that. We are doing...
Yeah, so
go ahead.
I agree, and I think that was super clear. So how I think about it, because I had to break it down and simplify it for myself. So there's three things: video, phone, portal.
That's exactly right.
The one that reimburses the most, which is the same as in clinic, is video.
Video, audio, yeah.
Yeah, audio. But that's how I break it down, is there's video, telephone, portal.
Yep.
You can get paid for all of them. Portal and telephone are much lower because it's not paying you at what a clinic visit is paying you. So I just think video is the best.
And not only that, the portal visits and also the G code, the G2012, 2010, those have a lot of other requirements that you must satisfy. And not only that, the reimbursement is definitely, I hate to say this, but it's definitely not worth your effort when it comes to Medicare payment to the provider. Yeah. So yeah. I think for anyone who's thinking about implementing telemedicine, you should consider billing using E&M rules. And I think, Kelly, you are a moderator on the Facebook group. I think you will probably agree with me that we are really seeing how a lot of people don't have a good understanding of E&M billing.
Right. Yeah. I mean, the basics of billing, which you have to understand, is how to code for the follow-up clinic visits in the first place. And then they're kind of freaking out's the wrong word, but they're like, what do I do about the physical exam? And it's like, okay, that's a fundamental misunderstanding of what's needed for a follow-up visit, where you don't have to have a documented physical exam.
Correct.
If you do 2 out of 3 for a follow-up visit, so always medical decision-making, and then usually it's going to be your HPI that's going to do it for you. So, and you know, a lot of urology is pelvic stuff. Not everybody can be a telehealth follow-up.
Correct.
But I can give some examples of great telehealth follow-up that I've already done this week.
Yeah.
Just to help people start brainstorming about it.
Yeah, the type of patients.
Yeah, so the type of patients. So one guy was a follow-up PSA, active surveillance of prostate cancer. I set him up for his next prostate biopsy and maybe refill the BPH med. Another one was follow-up interstitial cystitis. She was stable and doing great. I refilled some meds. One of them was follow-up biopsy. So that one I actually did bill on time because it was kind of a complex and it took a while. So that was kind of just follow-up path. So none of these people actually have to be seen in clinic for any of these conditions.
Got it. Let's see. What are some of the visits today? Let's see. Elevated PSA follow-up on a patient who actually had a urolift about 6 weeks ago. So he had 2 problems and he did great. His AUA symptom score dropped, and I'm dealing with BPH with urinary obstruction and elevated PSA. He's already had multiple biopsies that show no cancer. So we decided to simply follow up with checking another serologic testing in about a year and DRE in a year. And I'll check a cystometric evaluation of his lower urinary tract symptoms on follow-up. And the other one was there was a scrotal mass after ultrasound imaging. I reviewed the imaging personally here locally here at the office, and then through the telemedicine visit, we came up with a follow-up plan regarding what the results showed and what's comfortable for the patient. Actually, the patient was on telemedicine, but then had a conference call linked in with somebody else, one of his family members. So it was like a 3-person visit, except it's kind of linked in a roundabout way. So that worked out really, really well too. Other follow-ups. Let's see, like after any sort of testing, genomic testing, you want to follow up with the patient. I also wrote down maybe follow up after CT for flank pain, which is one of the patients that I saw today. He came in, he's a recurrent stone former with flank pain, and we did imaging and showed multiple abnormalities on the CT. So we went over all that. So that's for those of you who are interested, that's a new problem requiring additional workup. So that's a 99214 visit, FYI.
Yep.
Yeah, so it's not just a 99213. And I think the underlying message that Kelly and I is trying to tell you is that you have to understand coding and billing, E&M rules, with or without telemedicine. So
right. And a big asterisk on that is it's all changing January 1st, 2021.
Yeah, you read my mind.
Learn it now, but then you'll be all the better for learning the new rules, because it's going to be subtle changes, but
it really builds on itself.
Yeah.
Okay, Marina asks, if you are using Zoom now, why aren't you using it for clinic?
Okay. I think Doxy, number one, it's set up for telehealth. I think it's very user friendly. Just sends them a link, and my platform's friendly. The patient receiving it is very friendly. And I just hadn't played with Zoom as far as inviting patients. I know some people are using it, but that's my why.
Yeah, so I've seen the paid version of Zoom and also the free version, which is what I'm using right now. It is definitely not as easy as Doxy.me. And again, kudos to the CEO of Doxy.me for making it so easy for so many people. Marina said, go ahead.
I talked to a surgeon who is on Epic, because Marina, I think you're on Epic. So I talked to a surgeon on Epic, and within Epic, they have their own telemedicine, but my understanding is it's a massive financial add-on product. So it's like,
yeah,
Doxy.me, and maybe system-wide it's worth it, but Doxy.me for $35 per provider, or the free one, is like, why wait for that Epic to kick in?
Yeah,
a lot of people have their Epic product doesn't have telemedicine integrated. It's an add-on.
Yeah. And same thing with my EHR, which is Allscripts. They offer two different solutions, and I hate to say it, all these platforms that are sitting around trying to gouge providers with more money, they're just going to be kicked out to the wayside.
They lost.
They lost. They totally lost. Marina said, how much time per patient did you allocate when you started, and how about now?
So with my 3-day experience, we're just doing our follow-up visits are 15-minute follow-up visits. That's just the way our clinic's built. And then the nice thing about Doxy.me, it'll tell you how long your phone call is taking, or your televisit's taking. So I'm kind of just tracking how long is it to talk to people. It is faster. It is way faster than a 15-minute 15-minute block. So how I see this changing is right now we're telehealth wherever, just to get patients seen, and but where I see this going is to have an afternoon of telehealth and just say, hey, I do my telehealth on Tuesday afternoons, and so we can just batch them, because I have to plug in my dual monitor. I've got to get my scribe kicked over. To have it all streamlined, it would be great. And I'm going to do it in 10-minute visits.
Yeah.
Because I've only had one take longer than 10 minutes, and that was a cancer consult. So I think we're going to find that I can actually see more patients, AKA more RVUs, because of telehealth. I just find that patients, they're super stoked. They didn't have to get in their car, wait in your waiting room.
Yeah.
Wait for the other patient. They're stoked that they're on their couch, and we're just getting to business all the faster.
Yeah.
Hi, how are you? Okay, how's your bladder? How are your meds? Blah, blah. We get to it a lot faster. And I don't think they're expecting this big visit because they had to do this big thing to get to you. So I'm seeing a lot of patients in 5 minutes. John, I know you're already really fast, but for me, I'm like, this is fast.
Yeah. So my appointments are 10 minutes, and I agree with you, Kelly, as far as getting right down to business. It seems like for whatever reason, using this remote platform, people are just right down to business. And Christina Rose says, patients tend to get off track easily. How do you keep it on track and to the point? Also, how much time do you give for the telehealth call? So for me, it's 10 minutes, and I think Kelly is moving to 10 minutes as well.
And I would say, was that Christina who asked that?
Christina Rose, yeah.
Yeah, Christina, I see a lot of really chatty patients. I'm not as fast as John, and I think it's faster. I really think it's faster via telehealth. You get to the point, and then you say, "Is there anything else I can do for you today?" Nope. Great to see you. We'll see you for your cystoscopy. Okay, bye. Click. Like, it's faster.
Yeah. You would, for me, it's no different because I try to redirect the patient. For those who are super circumloquacious, you have to direct the patients. Otherwise, they would start talking about fishing and their last Alaska trip, and you have 50 patients waiting for you. So you can't, unfortunately, you can't diddly dally like that.
But I think telehealth it's not taking longer. It's definitely shorter.
Once the patient signs on, and like Kelly said, doxy.me is so straightforward and easy. 88-year-old can do it. I think you're good. I think just like most other things, the major hurdle and resistance comes from the providers and the office. So it's not from the platform. The technology is there. Joe, are the private payers mostly on board with this? Are you having front desk verify telemed benefits for private payers? So that's jumping ahead a little bit. Well, yes, as a matter of fact, we do verify the benefits for the private payers. What about you, Kelly?
We haven't done that yet. We just want patients seen right now. So we're learning by doing. I think we'll kind of see how billing kicks back. So yeah, we're kind of more into like get our patients seen right now than a lot of barriers. So stay tuned. But the way Medicare's opened up on this, private payers are going to follow.
Yeah.
And demand it.
Yeah, and I think, well, we'll see how it works. I think I sense that based on the chatter that I've seen, that a lot of physicians are not going to quite understand the billing and coding aspect, so they are going to struggle with that. But hopefully through this conference or meeting or interview, that they have a much better understanding. And when it comes to the billing, place of service code is 02, by the way, for those of you who are billing Medicare. Place of service is 02. And for your private payers, you may need the current modifier, which is modifier 95. And for the legacy payers who have not caught on, maybe the GT, Golf Tango modifier, who knows? For private payers, anything goes. They may want 02 GT and 95, or maybe just a 02 GT modifier. So you're just going to have to play with it. And if you find out in your area, in your state, what works for what payer, please leave it in the comments, or maybe leave it in the Thriving Urology Practice Facebook group and share with everybody. Jackie says, that was great. I have a new perspective about it, and we'll look at doxy.me. There are so many visits that really could be done on telehealth that we see in the office. So I completely agree. And we are finding that,
if we've done anything, because a lot of people are like, who's going to do this? What patient's going to do it? And if you can hear from John and me of like, these are the patients that are perfect for it. And we've had 88-year-olds already like think that they're kind of fancy because they've done it. Like it's more patients than you think.
100%.
Like overactive bladder is another great one. You see a patient, you do the exam, you send them to physical therapy, you start an anticholinergic, whatever your story may be. You don't need to see them in person to say, hey, how did that work? Are you ready to move on to Botox? Or are you happy?
Correct.
So I see tons of overactive bladder. Those follow-ups can all be telehealth.
And same thing with a lot of BPH with urinary obstruction. For those of you who are managing the patients on medication, which you should consider not doing, instead you should cure them or maybe return them back to their PCPs. But anyway, for those of you who are actually managing patients on medical therapy, a lot of those visits, if you're not doing any cystometrics, a lot of those visits can be done virtually.
Yeah, so, and where I see us going, so we have, for our return, we'll say return to clinic, blah, blah, blah. I think we'll end up doing a radio button that's going to be specifically telehealth.
So for me...
You're going to set it up as a telehealth appointment.
Yeah, so for me, going through the encounter, seeing the patients virtually, and then afterwards, that's the reason I asked how you do the follow-up. You document the same way in your EHR. For me, I set up a whole list of virtual visit follow-up. So virtual telemedicine, virtual visit in 1 month, 1 week, 2 weeks, 2 months. And all I have to do at the end of the visit is to pick when I want the patient to follow up. And also if I order something, I would say a virtual visit after imaging study or lab study. So my checkout person at the end of the virtual visit will look at that encounter and contact the patient to set up the appropriate imaging labs and then set up the virtual visit appointment with the patient. So every clinic, you all need to think about this entire workflow and how you are going to close that loop.
How have you thought about incorporating an AUA symptom score into a virtual visit? Are you going to have your nurse complete that with the patient in the morning as they contact them? Or are you going to take the time to be like 1 through 5, 1 through 5, 1 through 5?
You know, come on, you know me. I'm not going to take the time.
Nope.
The most efficient way is to get that information, get that blank form to the patient. And that's what we did. We emailed that form to the patient. He filled it out before the telemedicine visit. And I simply asked, well, what's the score and which ones you picked that are positive? He tried to show it to me on the video, on the phone or the camera. It did not show well enough. Maybe the free version doesn't give you a high enough definition, resolution, or maybe the signal is not very strong from the patient. If they are doing it through 4G and not through their Wi-Fi, it may not give you the perfect image quality.
Yep. And how I see doing it, because again, I don't want to ask the patient an AUA symptom score and calculate it. It's not time efficient for a doctor to do that. Is I'll have my nurse ask that and run it and then put it in the chart before she kicks it over to me.
Yeah. So we're going to have to figure out how to make that even more, like phone call from the billing staff, phone call from the medical assistant, and then finally the virtual visit. So we've got to figure out a way to streamline that even more in the future. So sleep on that, trying to figure that out. The other thing is, I know you've only been doing it for a few days. What about patient appointment reminders? I know for in real life visits, we use texting and email and stuff like that. What have you thought about implementing that, and how are you implementing that in your platform?
So our EMR we have a program that sends out appointment reminders, and how they're booked right now is as if they're in clinic. It just says telehealth on it, so they're still going to get those same reminders. Yeah,
same with us, and I think we are. We're trying to set it up. We use something called Demand Force. We're trying to set it up so that maybe they can get a customized reminder with the link to click on.
Yeah.
What a lot of the front desk staff are doing is that they are actually emailing the patient the date and the time of the appointment, and also here's the link to click on for your virtual appointment. So a lot of different ways that you can do this. Floyd, Dr. Seskin asked, can you use Doxy.me with any EMR?
Yeah, it's totally separate. It's totally separate. So it's not in your EMR. And that's why I have a split screen. So I have my EMR on one screen, and then I have a browser open. You have to use Chrome or Firefox, not Internet Explorer with Doxy. So that's open on a separate screen. So it doesn't matter what your EMR. You can be have a paper EMR and use Doxy. Yeah, it's platform agnostic, Dr. Seskin. So you can use Doxy with any EHR. It's like a browser that you open up. So you don't have it's platform agnostic, and it works for Android, Apple, PC. It works on pretty much everything. Jackie asked. I think it's worth mentioning, John, that CMS just got rid of HIPAA requirements in this time of need. So you can technically use FaceTime through Facebook. You can technically use Skype to do it. But to me, it's like Doxy.me is already HIPAA compliant. It's already very user friendly, and it's free if you want to use the free version. So it's like, why mess around with FaceTime and Skype with patients? Just get them on board and used to one platform that's going to work no matter what the HIPAA requirements are coming down the road.
Correct. And also you get a BAA, a Business Associates Agreement, and you are compliant even after the national emergency is over. Jackie asked, this is great. I have a new perspective about it. We'll look at Docu. Okay. Karen asked, do you need the modifier for Medicare or just the CPT?
Modifier for Medicare.
Yeah, so you need the place of service is 02 for sure.
I mean, and the reason is not much is logical, but the reason is they're going to keep track. They're going to see how many people are using, like, it's a way to keep track of what's going on. That's
Yeah.
what the modifier is for. You're not getting paid any differently.
Correct. And Joe asks, are you seeing any patients in the office at this time? So it's kind of like a little off topic, but somewhat related.
Yeah, I mean, there's still urology even in needs of national crisis. It's good to be a urologist, but I mean, there's tons of stuff you can't do tele. I can't pee. I have an obstructing stone. There's lots of emergent things, and I think our role is to try to keep these people out of the hospitals right now. So absolutely, there's a need to, as much as you can, limit. Everybody's having this discussion, and it's complicated. But I think there is an emergent clinical urology that still needs to happen. Otherwise, it all goes to the ER.
Right. And the whole idea is to avoid sending patients to urgent care or the ER because they are already being overwhelmed. I mean, during the winter, I don't know how it is in Washington, but here in Arizona, this is winter visitor haven. We call them snowbirds, the other white meat. So winter visitors come, and then our hospitals are almost always at capacity, even without the coronavirus. So our goal is to keep the patients out of the hospitals, out of the ERs, out of the urgent cares. Enough people are hysterical and stressed about and anxious about coronavirus. So they're going to get a lot of negative visits that don't need to go. And we're doing whatever we can to minimize the patient's visit to the ER or urgent care.
Yeah, I think it's worth mentioning new patient visits with telehealth. So we reached out to our insurer to say, hey, in this time of crisis, would you consider new patient visits? And they did say yes, whether that's going to be temporary or not. So that's med mal on new patients. Number two, coding on new patients, you do need a physical exam. A lot of my patients are pelvic exams. So you're not going to be able to bill a comprehensive worthy of urology if you are seeing them for pelvic issues. And then also a lot of paperwork and signed consents that we haven't figured out how to get that to a new patient yet, and have them sign that and have that all in our chart. So right now, I mean, things change daily, but right now for those reasons, we're not seeing new patients. But I know a lot of people with telehealth are seeing new patients remotely, and then having them come back for a physical exam when times are right. So I think it's different for everybody on if new patient exams via telemedicine is right for you and your practice.
Correct. And I'm also not seeing new patients via telemedicine because I think that initial visit is important for many reasons to be face-to-face. And also I want to be able to examine the patient, touch the patient, actually smell the patient sometimes because that gives you information as well. So I opted to see just the I opted to see just established patients and not new patients using telemedicine for now. And Joe wants to know if we're seeing patients in the office. Yes, we're still seeing patients in the office for a lot of procedures that were scheduled before, pre-COVID-19. We're still doing those, and I'm being extremely mindful. Whatever I do here, I want to make sure that I don't cause the patient to end up in the ER. So doing very minimally invasive stuff like I usually do. So keep that in mind. Nothing.
Yeah, I mean, I think there's no right answer on this. I think it's a huge topic in the forums right now of do you close your clinic completely? What do you do? I have a patient who was stented for an obstructing stone. She was set up for an ESWL at the hospital. The hospital canceled those cases. She is in distress with her stent. She cannot work because of her stent pain. And I'm like, I can't get your stone treated. But for her stone's little. And I'm like, listen, this is not orthodox, but let's pull your stent and see if that dilation is going to let the stone pass. So I'm open to pull that stent so that she can hopefully get back to work. So yeah. For me, shutting down completely is she's just going to be in the ER with stent pain. So there's no right answer. Yeah. But she couldn't have her surgery. Right? Yeah. So
same. I got something similar too. Person with bilateral stents after ESWL with large stones, and the stents are bothering him. So he really wants to have treatment, but it's elective. So elective surgeries are being canceled by hospitals. We don't want to tax the resources that are already scarce. So we are ending up having to cancel a lot of all the elective surgeries. Unless it's an
Yeah.
obstructing stone. I am operating on an obstructing stone coming up next week.
Mhm.
That's chronic. The other thing is you when you see the patient, this is very, very minor. When I send the follow-up letter to primary referring doctors, the letter, you may want to look at the letter, what it says. You may want to say, make sure that it doesn't say, I saw the patient in the office today. Here are my impressions, right? So you want to make sure that the patient was seen and leave it kind of vague so that there's no discrepancy. It's minor,
Yeah.
but you gotta look at the entire patient care cycle and not just the telemedicine visit component and the billing component.
But don't let it overwhelm you.
Yeah, it just
It is easy.
Yeah, just do it. If Kelly and I can do it, you can definitely do it.
Our really big primary care system in town just switched to telemedicine 2 this week. So they're all going through the same thing. So they're not going to look at you like, what do you mean you're doing like everybody's doing it together.
Yeah.
So I think very, very rapidly, it's going to be a very normal way to follow up on patients.
I agree. I think it's going to be phenomenal. Aunt San, I can never figure out who this person is. What does Dr. Casperson's consent form look like, as detailed as Dr. Lin?
No, we're not emailing them a paper consent. We're doing a verbal consent over the phone and then dot phrasing that into the chart.
Yeah, and I do both because I'm risk averse, overly risk averse. Dr. Grotas from New York, you document in your EMR during the doxy visit or just after? During or after? Oh, okay. Are you doing the documentation or doing it after?
I have a scribe.
Well, Dr. Grotas has a virtual scribe as well.
Yeah, so that's right, Aaron. We're like twins on different coasts.
Yeah.
Aaron just started on Doxy.me too. I have a scribe, so he's renewing the medications, he's putting in the cysto recalls. I always go through my charts afterwards. It's not any different. But yeah, if you don't have a scribe, like you might be looking down or over at your screen while and I'm looking at my screen and like looking at when was the last cysto, looking at the path results. I don't think that you don't have to be staring at your camera the entire time. It gets awkward anyways. This is not how people always talk to each other. So,
well, I try to get out of my comfort zone, right? I try to stare at the person's eyes for a little bit longer than what they're used to. That's me trying to push my boundaries.
Right. But I think that's what Aaron's question is split screens, right? If you don't have a split screen and you're trying to like minimize and then see, and it's easy. It's not mandatory.
Yeah.
You can always probably minimize the telehealth screen.
Yeah. So
if you have one screen.
I don't know if you caught this, Aaron, but Kelly and I both have dual monitors. I have a couple of huge monitors in front of me right now, and one screen was open to Doxy, and then this screen is actually open to my EHR. What I also do is I look at the patient's visit beforehand, so I already know the results, and actually after the medical assistants send the chart to me, I start the documentation of the results. And I know I'm going to talk to the patient about the results. And I know
that's what also makes your visit shorter, right? Is because you already know the history, but you're pretty sure you know what the plan is. You're just going to talk the patient through it and get them there. So that also shortens your telemedicine visit because you've already done that work.
Yeah. But I didn't, for instance, this patient who roped in a family member, so I had to document, spoke with the patient and the patient's sibling or whatever regarding the situation, because I'm that detailed when it comes to the visit. Who was actually in the visit. I just like in real life. If I see a patient and the wife is there, I document that the wife is present in the room. So no different. And
yeah, same with me. I had a patient and her daughter was on a cell phone on her table. So there's lots of people involved.
I've gone as far as, this is like prelude to telemedicine, I guess, right? I actually had an elderly patient who wanted to video stream the visit. And so I brought in my tripod, set it in the room, and used their phone and started a FaceTime visit with the guest that is out of state. So that is it's like a visit that had multiple people in it. So kind of like a prelude.
You're one step away from miking them up. You're like, let me get you a mic. They'll be able to hear you better.
And I have that.
Yep.
Joe Hughes says, when do you get the verbal consent for telemedicine? When the telemedicine appointment is set. I mean, you can do it. You can do it through your medical assistant if you want. I simply ask it real quick. Hey, is this okay with you? You don't have to do this. Here are the risks and here are the benefits. So people are on board. This is not rocket science. Kelly, you are great. Your patients must love you. Jackie says.
Thanks, Jackie.
Yeah,
that's super nice of you.
Aaron says you should have a script you read. This is a telehealth visit. Blah blah blah. Yeah, once you do it enough, it'll be second nature. Dr. Wolf from Colorado, you can add more than one person to the visit with Doxy. Have you done this? Yes. You must have come in a little bit later. Dr. Casperson, Kelly actually had done that. Actually, she does that with every visit because she has a virtual scribe who is that second or the third person in a visit without the video or the audio turned on for the scribe. So that scribe is documenting on Dr. Casperson or Kelly's behalf. Okay, so very good. We talked about office policy. Okay, new patients, we talked about that. We talked about state regulation and federal regulation. And lastly, we'll briefly cover, we already covered it already, is the financial or the coding and the billing aspect. We already talked about the type of visit that you can use for telemedicine. And I think I encourage everyone to look into billing using the typical E&M visit. And if you want, just start out with established patients, which is a lot easier. And also, site of service for Medicare is 02. You need to talk to your coders and billers. And for private payers, it's either GT or 95 modifier. And for those of you who are not in medicine listening to this, yes, it is this ridiculous, it is this complicated to see a patient and to get paid for it.
Yeah, and I think, going back to, if you start reading about it and what's covered and what's not covered, again, think of the three things: video, telephone, portal. Telephone and portal, just because they're covered services, doesn't mean it's worth your time. Much lower reimbursed than a established office visit, same cost.
And a lot more hoops that you have to check.
Way more hoops. You haven't seen the patient in 7 days. It's not going to result in the next available visit or within 7 days. Cumulative time over the last 7 days.
Has to be patient initiated.
A patient. So I had a patient needed med. This is a great COVID thing, right? So wanted their alpha block BPH medicines renewed. Hadn't seen them in 2 years. So no, you have to, in our clinic, you have to be seen within a year.
Same here.
But they're still an established patient because it hasn't been past 4 years. 4 years, 3 years. Remind me.
It's after 3 years.
3 years. So still an established patient. So we said, hey, why don't you do a telehealth visit? We'll renew your meds. Easy.
Yeah. That's or recurrent UTI. That's another one. After you've done a full evaluation. And I think you and I both disagree with the AUA recommendations to not work up the patients at all before you treat the recurrent UTI. They just came out.
So I do urine cultures. If you think you have a UTI, I demand a urine culture. That's my policy because I see way too many people that don't have bacteria as the cause of their symptoms.
Yeah, me too.
So if somebody calls in with a UTI, we'll still do a telehealth. We'll just have them come in and drop off a urine here or at a local lab. UTIs, level 4s, people, level 4s for UTIs. New problem, further workup planned, prescription medication.
Yeah, again, you have to understand the E&M rules. And like Kelly said, it's changing in 2021. So for the better. And I think it's going to open up the door for even more and easier telemedicine visits. So.
Yeah, absolutely. Yeah, and if anybody was confused about, I know a lot of us see recurring UTIs. If you want me to go into why a UTI is a level 4, let me know. I'll do a video.
Yeah. Or why in 2020 a vasectomy new patient's a 99204. There's a YouTube video about that too. Okay. Dr. Groda says level up the Kelly. Jackie says $15 for 10 minutes. Yeah, so I think we covered a lot of stuff, legal aspects, the logistics for sure, and also briefly the coding and billing. And I love the way you think about it. It's telephone, portal, or just regular E&M visit.
Yep, and then convert your portals and your telephones to telehealth.
Correct. I think a lot of people, one of the most common questions asked is, if I simply get on the phone with the patient and give the results to the patient, what code do I use?
Don't do it. No, we do it a lot. But so you cannot, it's not E&M. Correct me if I'm wrong. John's the boss. I'm like the vice president.
No, you're correct. It's not going to be an E&M visit.
If you aren't interpreting or doing something because of the result, that's not medical. That's not E&M. So I'm like, hey, John, nice to see you. Your creatinine is 1.2. Okay, bye. That's just giving a result. But if you're saying, hey, your prostate biopsy is negative, and let's continue to follow your PSA yearly, I'm going to put in to see you in a year with a PSA. You made a decision on that negative biopsy, and I would say that's a telehealth visit.
And again, you have to satisfy all the criteria, right? Not emanating from the last 7 days. Does it result in a visit in 24 hours or the next available appointment? So, like Kelly said, don't if you can avoid the portal and also the 2012 and 2010 visits to keep your life easier, and really just to, no matter what you do, you are assuming the medical legal liability, right? So you should do things that will benefit you and the patient, and obviously take care of the patient, number one. But you should be efficient with your time. Go ahead.
The other thing for the portal is you have to have patient consent to be billed for a portal charge. So how do you get consent via a portal? Do you have to call them? To me, it's like, now that telemedicine has been set up and it's fast and it's efficient, it's like, convert your portal questions to a telemedicine visit. Because how do you consent somebody via the portal that a portal charge is okay? Like, it's complicated.
It's already bad enough that you lose the nuance, right? I mean, look at social media. You lose the nuance when you write a message. Some people can construe that as being offensive when you're just being snarky. So that context is lost when you're just texting back and forth. But with voice and with video, you capture a lot of that, and you can read the patient a lot better with this format anyway. So I think this is hopefully going to be the way to go in the future for a lot of our colleagues.
Yeah, I mean, John and I are already very comfortable with our face being on video. So, there might be people who are like, video. Like, you'll get over it. Do it 5 times, you'll get over it.
Yeah.
And you can smile at your patients and you wave hi and like. And here's the other thing: you can wear jeans and drink coffee.
Yeah, there you go. I've got my cup right here.
So I love it. I'm like, I'm well hydrated. I get to drink coffee while talking to patients.
Right, and then you can give them the thumbs up. They can see you. It's really awesome.
I had to pay my very first telehealth patient this week. He got his dog up on the couch and showed me, because I know about his dog. Like, we've talked about his dog for years. I got to see his dog.
Oh my gosh, a different way of connecting that you never even thought of. Yeah, it was
very cool.
And pretty soon you're gonna have patients walking around their home and show you different things.
Yeah, I'm still going to try to keep I'm still going to try to keep it 10 minutes.
Yeah. Aunt San says, thank you, Jackie. I see now that telehealth is the way to go. Dr. Gordo's happy hour with Kelly and John. Next time we meet, buddy, I'm buying.
Awesome.
Okay. Aunt San, do I have to have the patient originated telemedicine statement in the consent?
Yes, I would say yes. Because one of the criteria is it's a patient-initiated visit.
For the telemedicine statement consent. For the Medicare patient?
Yep. We have it in our dot phrase.
Yeah. And Michael, Dr. Hayeri, yes, please explain how you do level 4 if it's not new diagnosis. Dr. Hayeri, the only recommendation is the recommendations that I've given you for years is that please attend a coding course. and you can look on Doctor, I think, didn't you do a video on the 992? No, you never did one. You know what? You should do one on the Thriving Urology Practice Facebook group so Dr. Hayuri can see it. Why?
Oh yeah, I did it for my other group.
Yeah, you did it for your female in urology Facebook group.
Female in urology group.
Yeah. Karen Brown says, thank you both for taking the time to share your experiences and help educate us. You're very welcome. Dr. Grotas, I want to do what's a level 5. I want to do what's a level 5 follow-up, not cancer. Huh? I don't quite get that. A level 5. Level 5 established? Level 5 established will probably require a lot of, to get a level 5, you probably need, obviously, multiple established problems, maybe exacerbating, and a lot of data. In the data section.
Lots of data.
In the data section.
Looking at images, 2 points.
Yeah.
Summary of old records in your chart, 2 points. So you do your high yield ones.
That's already a level 5.
Yeah, which will get you 5.
Yeah, that's a level 5 on the. That's a level 5 on the data section.
Yep, and then new problem, further workup planned. Otherwise, you'd need exacerbating multiple exacerbating. That's going to be harder.
Right. So again, it's what we're talking about is the medical decision making portion of the E&M visit, which comprises of multiple elements, and you only need 2 of the 3 elements within medical decision making to reach a level in medical decision making. So, yeah, again, it's knowing E&M and understanding it in the past is only going to help you in the future if you want to continue participating in seeing Medicare patients and private payers and participate in the insurance game.
Yeah, understand it. I think people are undercoding a lot. Urology has complex sick patients.
Yeah.
Lots of workups.
Jackie, follow Medicare rules and most insurance companies do the same. We agree. Marina, what do you do if a patient wants to show you a part of their body for visual examination? Great question.
I'd say do it.
Yeah, I agree. So doxy.me, no, you don't want to do it on Facebook Live, obviously. You want to do it on a private, not a public-facing platform. You want to use a private-facing platform. And if you are using like doxy.me or Zoom for Healthcare or Google Suite, which is HIPAA compliant, and they'll generate a BAA for you. Those are not public-facing platforms, and you should be just fine. And as a matter of fact, that's a good reason to upgrade in Doxy so that you get the high resolution image so that you can see clearly what they're showing you.
Yeah, I mean, it can still be goofy. You know, I had a patient who was on the couch, and then behind them was a big picture window, so it was all this light coming in. I couldn't see their face well. Like, you know, there's going to be limitations, but you just decide. You'd be like, I can't see that well enough. You know, schedule a visit.
And if you want to know how Kelly looks so good and how I look so good, we will be happy to do another video on how to set up your studio or environment so that you look good.
I actually have, so I'm just using my computer mic, so it's not great. I have a ring light that has burnt out because we've been talking for like 40 minutes. But behind me, I have a big stick light, which is why you're seeing that. So I have another, in addition to my room light. So you can see I have a shadow back there because I have a big stick light on over there too.
Okay. I've got secrets. Yeah.
Secrets to looking good. Don't have shadows.
So anyway. Yeah. So the patients, obviously, you want to, you know, if you can't see them and you want to see them, obviously move them in front of a light. I'm running 2 huge studio lights here and a hair light above me, believe it or not. So yeah, I'm fully set up from doing previous videos, and this is just a smooth, super smooth transition. Dr. Groto says Doxy.me has cool screen for the chair. Oh, Doxy.me. Okay, I know what he's talking about. There's an attachment that you can purchase that goes on the back of the chair, and it's like a blue screen or green screen that eliminates the clutter in the back of your office.
Oh, no way.
Yeah.
I already have a very clean wall.
Yeah. So. Awesome. All right. I don't see any other questions. Any parting thoughts, Kelly?
Do it. We did it. It is easy, and you'll be like, thank goodness that this is here now.
Yeah,
you'll keep using it when COVID's done. Absolutely.
Right, and that's one of my parting thoughts is whatever you are doing now, do it and plan for the long term, and that you're going to continue to do it. That's why the BAA, that's why the HIPAA compliant platform that we both have chosen, and also thinking about the workflow, setting that up so that you do it once and then you just simply tweak it minimally in the future. So that you'll be able to continue to see your telehealth patients.
Yeah, and I'm happy too. John's getting DM'd like crazy. Like, shoot me a DM. Happy to talk people through it.
All right. Well, thank you so much, Kelly.
Awesome.
All right. If you guys have any questions, obviously leave them in the comments below, and I'll probably plan to upload this on YouTube, and maybe Kelly can share it on your groups and stuff like that. I'll definitely share it on the Thriving Urology Practice Facebook group. Be well, take care, and finally, about COVID. Any parting thoughts on COVID, Kelly?
Wash your hands. We're all fomites. You just give yourself grace, like it is literally day by day. Give yourself grace. Be prepared that this is ever changing, and we're all in it together.
Yep, I agree. And also, humans have lived through much greater and scarier infections and bugs. This will be just fine. We will all get through it. One thing is that, what is the motivation behind media, the mass media? It is to get you to watch. Just like, what is the purpose of Facebook? Facebook's goal is to keep you on their platform for as long as possible. That's why they do what they do. Make no mistake. Mass media, their goal is to get you to watch. So that's why there is something called what bleeds leads. So they constantly show murder, rape, because that we have this sick desire to see things like that. So keep that in the back of your mind, and think about why they keep reporting these stories. They don't report on hope, right? They report on mayhem, injury, death. So keep that in mind, and don't get sucked into this craziness. Wash your hands, social distancing, and what is really important that not many people are talking about is clean this thing right here. Clean your phone. And I know this has been in your bathroom, so don't lie to me. Wash your phones and clean your phones. All right. And and also be a little bit more diligent in cleaning the door handles and the doors, the front and back of the doors, and also the countertops. And that's pretty much it. It's nothing different than other viruses that we've encountered, including the common flu. And as a matter of fact, these precautions are nothing but common flu precautions. So we are just a little bit more stressed because the media has kind of hyped it up. And also, this is a new virus, so we don't really know the behavior of the virus. And that's why there's so much uncertainty and so much stress among people.
Yep. Don't forget to exercise. It's great for stress.
Yep, 100%. So how are these infections affecting us, right? How are you more likely to become infected when your immune system is low? Right? So how do you boost your immune system? Better sleep, right? Better mental hygiene, and a good diet and exercise. So do that to keep yourself healthy and be well. Bye-bye.
Awesome. Thanks, John.
Bye.
Bye.